Respected chairpersons, ladies and gentlemen, thank you very much for the kind introduction. And I'm very sorry that I missed the meeting yesterday, and probably I would miss later part of the day. It's just because we have a problem in our own hospital, because some of our colleagues are away to attend the academic meeting in the States. So, and as you have already learned from media coverage, there are huge issues with the junior doctors and their future training. So as a postgraduate supervisor, examiner, and a neurologist, I'm having some torrid times. So that's my apology, and I hope you would understand that. In terms of the presentation, it's a joint presentation from our center. I am a neurologist. I'm a general neurologist with some interest in fatigue disorders in neurology that I do see. Tim was my specialist registrar, and he has now moved on to become a consultant neurologist at Exeter, and Dominic is our pathologist who does part-time work in Cambridge, and most of the pathology work was carried out in Cambridge, where Dominic has better facilities. Now the question is, why should we be looking into pathology of any disease? And I think I tend to accept the view that pathology is the queen of medicine, and a disease can only be defined by its pathology. And what is also important is to define the progression of a disease in terms of pathology, because the intervention may be very different depending on at which stage we are seeing the patient. To give a very simple example, I think many years back, rheumatic fever was a major problem and health issue, and is straightforward, caused by a particular type of a bacteria called Streptococcus. And we know that rheumatic fever can affect joints, it can affect heart, and later on it can also have neurological problems. But the issue is, because we knew the pathology, the treatment was quite different depending on which part or which stage of the disease the patient presented with. So one could have prevented the disease outright by treating someone, a child usually with a sore throat, by giving some antibiotics. But if someone has had rheumatic heart disease for many years, then clearly the treatment would be replacement of the heart valve rather than giving antibiotics. So I think if we look at any disease, we have to recognize that a disease does progress through various stages, and the appropriateness of any intervention will have to be defined in terms of what stage we get our patient, and of course what pathology does that represent. So with that very brief introduction, I go into two cases which we have been able to study in some detail, and both patients had a clinical diagnosis of myalgic encephalomyelitis, chronic fatigue syndrome, or ME/CFS. The first case and the second case differs in one important respect, in that the time that passed with the onset of symptoms and subsequent and very unfortunate demise of these cases. So it was at the age of 11 that our first case developed symptoms of dizziness, headache, joint pain, hay fever, and very significant fatigue. And to an extent, it reflects what we would call pediatric ME or CFS case. And quite appropriately, the child, if I may say that, was referred to a neurologist, and who did a very good clinical examination and did not find any abnormality. Thank you. Unfortunately, symptoms progress with weight loss, and because of that, again, very appropriately, an endoscopy was carried out, which did not show any significant abnormality, and will show the biopsy, which we could trace back several years. He was still able to attend school, although was taking days off, and when at the age of 15, there was another bout of what was thought to be a very severe flu with back, neck, and abdominal pain, tiredness, and it progressed rapidly to a point where the child or the young adult was quite bedbound. Now, Dr. Morgan Hughes is a very good neurologist. He worked in Queen's Square and is considered to be an authority on mitochondrial disease. And again, I think the first case would show that how patients should be evaluated presenting with symptoms and problems which would be interpreted as neurological by simple common sense. So Morgan Hughes saw this patient, carried out relevant investigations, and gave a straightforward diagnosis of post-viral fatigue syndrome, which we would call ME/CFS. So again, at that point, we did not have any knowledge of treatment, so simple supportive measures were recommended, but the story continued to unfold with recurrent episodes of infection, severe fatigue, muscle ache, and psychiatric referral was made and antidepressants were started. Over the next decade, there was no improvement in any meaningful sense, and although there were some days where symptoms were less severe, overall symptoms continued to worsen over time. The patient was bedbound, progressively fatigued, and there was a very strong post-exertional component. Was unable to read newspapers, and the mother had to sit next and read out newspaper, and was unable to complete sentences and could not perform tasks. And during this period of time, he was admitted to Addenbrooke's Hospital in Cambridge, Bart's Northwick Park unit, where they had an interest in post-viral fatigue at that time, and also in psychiatric units. And the parents took their son to every possible specialist with an interest or knowledge in the condition. And again, I think this is a fairly familiar story which is replicated in the lives of many patients and their families, and continues to be the case now. And these were, in a summary, the results of investigations. And again, this is in contrast to the second case. The first patient was quite appropriately investigated, as we should be doing to any case presenting with a similar range of symptoms. And in terms of the cognition, there was minimal problem detected with the Mini-Mental Status Score, which is the common screening test which we use as neurologists. And there is an Addenbrooke's cognitive test which one should get out 100 out of 100, and he scored 91, largely because he was fatigued with timed tasks. Now, this is the small bowel biopsy, and it is normal. So there was no evidence of celiac disease or gluten enteropathy, which can present with weight loss and fatigue, and is always a very important condition to exclude in those who have irritable bowel type syndrome. But in this case, it was normal. This is the skeletal muscle biopsy, and I think it is instructive in many ways. Firstly, it is normal, and it tells us that muscle pathology is probably not the major issue in patients, or most patients, who present with ME/CFS. And secondly, the idea that patients who have this condition are experiencing symptoms largely due to deconditioning is probably also negated by findings of a fairly normal histology. Now, obviously, with time, when someone is unable to move, there would be changes in keeping with physical deconditioning, but that's not the cause. It's an effect of the disease, and that is very important to keep in mind. So this is again skeletal muscle biopsy with para-iodic acid Schiff, which is important because it shows the fiber type grouping, which tends to be abnormal if there were significant mitochondrial problems. Now, in terms of treatment, he was treated with intramuscular gamma globulin, which was considered to be somehow effective in some experts' view, and he did receive it. He had appropriate dietary restrictions. He took antidepressants, practically everything that one can recommend in terms of symptomatic treatment, cognitive behavior therapy, graded exercise, acupuncture. Again, the other issue we do see, and we have done previously a study in our patients that confirm many chronically and fairly severely housebound patients have significant loss of bone mineral density and are prone to develop accidental fractures quite easily. And you have to remember that this was a young man in his 20s who had an accidental fracture and was actually related to very severe loss of mineral from bones. So at the age of 32, he had a fatal overdose of analgesics and antidepressants, and we got involved at that stage to do, with the permission of his parents, a full pathological postmortem, which obviously we had to overcome a set of obstacles, because the first question was this was not necessary from the point of view of diagnosis, as it was a suicidal overdose. So firstly, we looked at spinal cord, and this is a cord stained with Luxel Blue Fast, which is LFB, and that showed fairly normal pattern of distribution of myelinated fibers. And that is also relevant only because sometimes we do come across very similar fatigue in patients with multiple sclerosis, and in this case we knew he did not have it because the MR brain scans was normal, but nonetheless we did not find any pathological signs of myelin loss in the spinal cord. We looked into the anterior horn cells, which are again in the spinal cord and are responsible for innervating muscles, and the reason for doing so is the parallel of ME chronic fatigue syndrome in terms of symptoms with post-poliomyelitis syndrome, where predominantly the burden of the disease falls into the anterior horn cells. And we did not find any significant loss of anterior horn cells, which again clearly establishes ME/CFS to be a condition which is not the same as post-poliomyelitis syndrome. This is again a large and magnified view of cervical expansion of the anterior horn cells. Now, we looked at the spinal cord at the point where nerve fibers which carry sensations of pain enter the spinal cord, and that is known as dorsal root entry zone. It's called dorsal because it has the posterior or towards the back of the spinal cord, and we stained that, and we found that there was something which wasn't quite right. And you can see that there are a fair number of these red dots in the area where the dorsal root entry zone is located. So this was certainly not what we would expect in someone who was entirely normal in the neurological terms. So this is again a magnified view, and when we start looking in the magnified view, you will find that some of these cells look like ordinary lymphocytes, but there are larger cells which seem to have a darker central inclusion body and a paler halo surrounding it, clustered around the area where nerve fibers actually get inside in order to travel up to the brain. Again, some additional views confirming those inclusion bodies, if we may use that word. And this is a different stain with pyridic acid Schiff, where those particular cells stand out very prominently. Then we looked at further pathways of sensory transmission, because one of the issues this particular patient had was very severe pain, and that was one of the major problems in the management, and one of the reasons perhaps he decided to take a fatal overdose. So although we talk about chronic fatigue in ME/CFS, what we often underestimate is the problem of chronic pain. And this is the posterior column, which does not carry pain, but is responsible for carrying joint position, sense, and vibration. And we found similar cells, or similar looking cells over there. And just to give you an idea that if we looked looked at a normal control, and that's where we have some problem in getting the work published, because we do have archival tissue of individuals who have died due to non-neurological causes, road traffic accident, even depressed, and we are able to examine that, but we cannot obviously publish those comparative results, as we never had in the past taken consent for doing so from the relatives of the deceased. And that's a peculiar situation in terms of the tissue archival law, that we cannot actually show this picture in a publication. And whatever I'm representing here has to be treated with confidence, as we can only do that for our own educational needs. This is again a myelin stain of the posterior column, and that's normal, but again, we'll find those cells. Then we looked into the sections of brain tissue, and this is the wall of third ventricle in the brain. Again, quite obvious inclusion bodies. This is substantia nigra, which is part of the dopaminergic cells, or cluster of cells which release dopamine, which is very important in motivation and also motor function, is also the area of the brain which is affected in Parkinson's disease. And the reason we wanted to look into basal ganglia was our view that fatigue, in a way, from a neural sense, can be generated in disorders which affect basal ganglia. So that was one of the reasons we wanted to look into it, and there was a significant collection of these cells. Now, just to go to the other areas of the nervous system, peripheral nerves, entirely normal, so there is no evidence of neuropathy. This is a longitudinal section, normal, muscle, normal. We didn't find any inclusion body. Going back to the brain, we looked all the way up to the cerebellar cortex, which is also known as the hindbrain and is very important for balance. And we know that disequilibrium is a problem in many patients, and quite surprisingly, we found a significant number of these bodies. But equally, there were clusters of what would be normally classified as inflammatory cells, a fairly robust number of these cells in relation to cerebellum. So we then took that forward, and that's where I think the Cambridge facilities were very helpful, that we did some electron microscopic structure, and eventually we confirmed that what we are seeing, which is this particular dense material, is nothing but corporamylacia. And this is something which even we don't understand it very well, but put very simply, corporamylacia is considered to be the product of metabolic outflow of neurons, which requires to be disposed of. So if neurons are stressed and they produce certain chemicals which, if kept within the neurons, are potentially toxic, there is a mechanism by which those material can be disposed of, and that is considered to be the basis of formation of corporamylacia. Now, that is not entirely untrue, because we do get corporamylacia, for example, in patients who have medial hippocampal sclerosis, which is a type of epilepsy when that part of the brain is continually irritated or stimulated. And if we remove that part of the brain, which is sometimes done for management of refractory epilepsy, we would find very, very dense clusters of corporamylacia in those areas. So there is some idea about corporamylacia being the byproduct of neuronal stress. And essentially, it comes also from the astrocytes and the glial cells, which support neuronal metabolism. And the third possibility for formation of corporamylacia is if complement systems have been activated in the past as a part of an inflammatory injury, then again, the body would try to remove those products after the inflammatory phase passes over and would form corporamylacia. So the most striking abnormality in this case was corporamylacia, and then we looked into the literature of corporamylacia in order to find out what are the conditions where we might get it, and they are relatively rare disorders. And what is absolutely striking is we do not find corporamylacia in any significant number in normal people under the age of 40 years. I'm not saying it's a part of an aging process necessarily, but even in normal brain, there is slow accumulation of corporamylacia over years, but it doesn't happen under 40 years of age, except in patients who may have Down syndrome. So apart from that category, corporamylacia collection is certainly not a sign of healthy, and in a very, very simplistic way, one might say that more corporamylacia means an aging brain or an accelerated aging process, which may link very nicely with an enhanced level of stress on the nervous system. Other causes of corporamylacia, which we could exclude quite clearly based on the whole body pathology we carried out, are very rare, including muscle storage disorders like Anderson's disease. The muscle was entirely normal, in epilepsy, and in rare conditions like Bielchowski body disease. But we also find it, as I said, in areas of gliosis in temporal lobe epilepsy and around multiple sclerosis plaques, again suggesting that these are products of metabolic stress on brain or nervous system. Now let's go into the second case, which is also very instructive. The major differences, as you will see, is the shortness of history, the difference in pathology, and also the change in the standard of clinical care offered to this patient. And this is really a gap of 10 years. The first patient had presented in the 80s, when I think most neurologists did accept post-viral fatigue, AMI chronic fatigue syndrome, as a valid neurological condition requiring appropriate investigations and exclusion of alternative diagnosis. Unfortunately, I think there was a shift in that view within next 10 years, which will be captured by the second case, which was, again, in a young lady of similar age, 32, when she died, and at the age of 26, had a flu-type illness, which led to very severe fatigue, became bed-bound by June 2000 with light and chemical sensitivity, developed low blood pressure, and was unable to take a full meal and needed to be fed with small volume meals. Due to very, very unfortunate circumstances, she was interned under Mental Health Act in 2003. And because of the stress related to the events surrounding that procedure and subsequent tribunal hearing and removal from GP list, she had a severe relapse of fatigue, and symptoms gradually went rapidly downhill from 2005 September. Severe pain and anorexia with loss of weight and dehydration. And I have to say that if any young person with a diagnosis of post-viral fatigue syndrome develops significant weight loss, it should ring an alarm bell. And I am not inclined to consider the diagnosis of psychological explanation behind that. Just to put the record straight, in anorexia nervosa, one critical difference is that they have a lot of energy as opposed to people who lose weight as part of post-viral fatigue. And passed away very sadly in November 2005. And we are quite indebted to the coroner, who very kindly agreed for a selected postmortem on spinal cord. We could not examine the brain because that was already examined by the coroner's pathologist as a part of the autopsy protocol. Now, the coroner had a right to refuse to give us access despite the relative's permission, but she was very kind, and we did collaborate with coroner's pathologist. And somewhat familiar picture again in the spinal cord, but when we looked at it under higher magnification, what was striking was that unlike the density of so-called corporamylacia, here we find a greater number of inflammatory cells. And these cells are actually being stained with a particular stain which makes them look brown, and is a CD8 positive T cells, which are called cytotoxic T cells, which are responsible for cellular or neurological damage. This is high power magnification, and if we go back a little bit, we know that there was this kind of a circle of cytotoxic lymphocytes around a central area in the dorsal root ganglia. If you remember, dorsal root ganglia is the gateway for carrying sensations from periphery to the brain. It's a relay station in real terms. And we really want to know that why there should be this kind of an infiltration. And we did a very old-fashioned stain, which was used to be done to detect viruses. And we first thought this might be a virus, but then we carried out a higher magnification study and eventually electron microscopy and found no viruses, but possible viral proteins. So there was no intact virus, but there were footprints of viruses. That's what we think, which is being looked at for confirmation by Dominic. So again, if we looked at the pathological diagnosis, we would say that it's a form of inflammation of dorsal nerve root. Please remember that this young patient had approximately 5 to 6 years of history, as opposed to 20 years plus history in the first case. Again, showing that the disease does evolve over time, and I do not think it's a great idea trying to manage everyone without looking into their duration of illness and nature of symptoms. Now, coming back to ganglionitis, we do see that as part of viral infection or rheumatological disorders, and sometimes even remote manifestations of malignancy, but we did not find any of these in the second case. And clearly, if those parts of spinal cord and the dorsal root entry zone are involved, certainly it would lead to very severe sensory symptoms, sensitivity, for example, to any sensory stimulation, and profound fatigue. But what is interesting, and that's the connection between the formation of corporamylacia. I was telling at the end of the first case that all we find here is a huge collection of the end product of what could have been stressful or inflammatory injury to the nerves. What we actually see in the second case is the evidence that there is a degree of inflammation in response to tissue injury, stress, or preceding viral infection, which probably and eventually leads to the formation of corporamylacia. Now, if we were to take that spinal cord and wanted to examine under MR spectroscopy, what we would see would be very similar to what we have already seen in living brain, in that they would have a peak of choline which comes out from the cell membrane of nerve cells, but also glial cells. Please remember that glia support nerves in their metabolism, and corporamylacia is formed predominantly from glial and also from neural end products of stress. So to summarize, I think we have to say that pathological changes in any chronic fatigue syndrome may reflect not only the duration of symptoms, but perhaps also the original trigger. However, I think if we want to put everything together, a common pathway will be the ion channel disturbance affecting cell membranes of excitable tissue, and by that I would suggest neural or nerve tissue. And there is a very good suggestion coming out of these very small number of pathological autopsy that progressive excitation and stressful injury may play a dominant role in the symptoms of any chronic fatigue syndrome. And I think in some ways our work does illustrate that ME/CFS is a unique disease in its own right, because these sort of changes and the pathological abnormalities which we have seen have not been mirrored in other neurological disorders. Of course, you can see sensory ganglionitis in neurological disease, but you find evidence of remote cancer or an ongoing herpes viral infection, which we didn't find. We can get corpora amylase in extensive numbers in aging brain, in Alzheimer's disease, in Down syndrome, but those conditions did not apply to these patients. So from that point of view, I think we have at least a beginning to identify and establish ME chronic fatigue syndrome as a valid problem and not something which simply comes off because of physical deconditioning and your disinclination to go back to work, which is the current psychosocial hypothesis. So what we have to emphasize as well, that we haven't said that chronic fatigue syndrome of the ME type carries a unique pathological signature. We don't expect it, because depending on the duration of symptoms, we cannot expect to find same pathology. But it would be nice if we could reproduce changes of very similar nature in other cases, and that is why I'm very keen to have a kind of agreement among various voluntary organizations to set up a national brain bank protocol, as we have for other neurological disorders such as Parkinson's disease or multiple sclerosis. Indeed, brain bank data have been used to redefine clinical diagnosis in these disorders, and I feel it would be a very important step to take our or anyone's research into the physical elements of the illness further. And I think, as I have already stated, that what we have found in two cases are very likely to represent two ends of a spectrum of neuronal changes, starting off what I believe is an inflammation and ending up with formation of what we would call inclusion bodies as a result of stressful and perhaps inflammatory injury to nerves and glial cells. I can say with some confidence that, again, looking through some of the depressed brain tissue, we did not find similar changes, and that would be one of the arguments to separate chronic fatigue syndrome of ME type from depression or somatization that we are currently told to be the main reason of the problem. So I would like ME to remain as a neurological condition, and I would like to see patients being seen by neurologists, but that would be a great challenge in the current environment, and I can only hope that there will be some change in the perception of physicians and perhaps politicians to recognize that by allowing a psychosocial paradigm to flourish in the past decade, we haven't probably helped any of our patients in real terms. Thank you very much for your kind attention.